I would try to get the connection to Chennai with Sivakumar.
Hi Mario, are you able
Siva,
to hear
can
me?
you hear us?
Yes, Mario, I am able to hear you very well. Are you able to hear me?
Yes, yes, we can hear you. Maybe the volume should be a bit higher up.
Okay, we will sort it out. And it's a pleasure to again come back live from Madras Medical Mission to you, Mario. And hi to Alison Sabalka and
Hello.
Eric Rosenthal whenever he's coming. It's always a pleasure. In the next 2 hour 20 minutes, we will be trying to transmit about 4 patients, and the first of the patient is going to be a very an interesting patient, a 4-year-old child who had a parachute mitral valve with severe mitral regurgitation. The surgeon had to do a melody valve surgical implantation at 2 years of age, and the child has a significant large paravalvar leak. And my colleague will give the clinical story of the patient. Can you show the PowerPoint presentation?
Uh, large mitral paravalvular leak after surgical melody implantation. This is a 4-year-old girl with a 12 kg body weight, one of the twin. She was diagnosed with Schoen complex with bicuspid aortic valve, severe AS, and parachute mitral valve with severe MR. At 8 months of age, in November 2019, she underwent a balloon aortic valvotomy, where the gradient reduced from 52 millimeters of mercury to 15 millimeters of mercury, with no evidence of any AR. At 2 years of age, subsequently, in May 2021, in view of severe MR associated with parachute mitral valve, she underwent a surgical melody valve implantation, expanded to 18 millimeters, with a pericardial belt stitched around the melody valve and anchored. In the early postoperative period, she was identified to have significant mitral paravalvular leak. There was progressive LA dilatation and pulmonary hypertension. She subsequently was started and currently on ANVAS, carvedilol, that is beta blockers, ACE inhibitors, along with diuretics as anti-failure medications. She has slow weight gain with effort intolerance. This is the chest X-ray of the baby with situs solitus levocardia. There is cardiomegaly with CTR of around 75%, which is mounted mostly by the LA shadow, which can be seen in the right heart border also. There is a stented valve which can be seen along with sternal wires. This is a chest X-ray which shows left atrial enlargement in a normal sinus rhythm with LV volume overload. This is the transthoracic 2D echo images which shows the 4-chamber view, where we can see the stented valve in situ along with moderate. There is a severe paravalvular leak which is located medially in the apical 4-chamber, as well as the parasternal long axis view as we can see it. This is the LA gradient, that is the mitral valve gradient, which we can see, where the mean gradient is around 9 millimeters of mercury. The LA is aneurysmally dilated to 8 centimeters, as we see in the parasternal short axis view. These are the two still images which shows a large anterior mitral paravalvular leak measuring 6 to 7 millimeters in the region of the right fibrous trigone.
That's a very interesting case.
Yep. Now, my colleague, Dr. Srija, who is the imaging expert, is going to show you live images that she has acquired so far. Full echo, please. Full echocardiogram.
Can I ask you a brief question before you start in a case? Well, the first question, is that the paravalvular leak present early after implantation, or it developed later on? Because if the second possibility, I wonder if there is some hypothesis.
Okay. Now,
endocarditis or anything else?
Yeah, interesting question, Dr. Mario. This patient's primary care cardiologist, Dr. Vishal Changela, is now with me here. And the story is that in the acute postoperative period, towards the time of discharge, and about 1 month later, this paravalvular leak was identified. Since it was a very small child and the anatomy is quite challenging, the child was managed with heart failure medications that includes furosemide, spironolactone, carvedilol, all the routine heart failure medications. So it started quite early. I agree with your concern that it may be a recent infection. There are no significant history of a long febrile illness at all in this child, and all the this problem was detected almost 2 years before. Now,
I'm also curious, it does look like the position of the valve is a little precarious. Sometimes you would adopt a potential redilation of the valve to try to modify the PVL. Do you think this valve is in a suitable position to attempt that to
Okay.
at least make the defect smaller?
okay, that's the surgeon's note is that he has stitched the valve at 1/3, 2/3 junction towards the, and that means 1/3 of the valve from the ventricular end and 2/3 from the atrial end. He put a pericardial hood and then he anchored it. However, with the pressure of the left ventricle, the valve is sort of looking migrated more towards the atria. I think, Alison, you will get more information when Srija shows you the transesophageal. Show big screen
Right.
transesophageal, big screen, full screen. Yeah, Srija, go from the first view.
Okay, good morning. These are the images which are acquired using a pediatric TE probe. So in this four-chamber view, you are seeing the melody valve in a supraannular position. Left atrium and left ventricle is dilated, signifying that the leak is quite large. On color interrogation of the melody valve, there is a flow acceleration across the valve. And you can already see a medial leak, which is happening there close to the interatrial septum. And this leak is actually anteromedial as we manipulate the probe. So this leak is a significant leak, and it was measuring close between 6 to 7 millimeter. I'll show the measurements. So this is the gradient across the melody valve, which is a mean of 14 millimeters of mercury at a heart rate of 122 beats per minute. And this is around the 40-degree view, again showing the leak. There appears to be a broad jet with some strut in between. So this is at 50-degree view. We can see that the broad medial jet. It is actually in the region of the right fibrous trigon. At around 120-degree, we can see in relation to the aorta that the origin of the leak, but the jet is quite eccentric, and you can see it skirting along and exiting into the left atrium. So somewhere around 6 to 7 millimeter was the measurement which we got at the origin of the leak. So that is the jet which is skirting into the LA from the region of the right fibrous trigon. Child also has a bicuspid aortic valve with a mild aortic stenosis that is causing a flow acceleration across the aortic valve. So this was our septal puncture under TE guidance. So we intended to puncture at the posterior inferior part of the septum since it's a medial leak, so that the direction of the sheath will be more oriented towards the leak. So that is the septal puncture needle which is indenting the atrial septum. And here it is in the posterior inferior part of the septum. The needle is indenting. This is a 90-degree view showing indentation in the same desired area.
I want a RCA guide catheter. Renal guide.
And we punctured in that region and entered in the left atrium as shown by the contrast which is filling the left atrium.
2 Vibos.
So this is the approximate relation between our site of puncture and the rough location of the leak, medial leak.
Get me that thermo catheter, like RC catheter.
I think that's.
So you heard you saw the images, Alison.
Yeah, I can see the where the transesophageal echo shows us the puncture and then the approach. It's a giant defect. Do you think your inflow gradient mean of 14 is due to flow? Because the leaflet motion looks quite good.
Absolutely. I think so. I think it is the large regurgitant orifice which is now entering the left atrium, which is going through again the mitral valve. And I totally agree with you that it is likely that it is the mitral regurgitation is causing the mitral regurgitation is now primarily causing that high gradients. Now the question
Siva,
is,
can you summarize what are your plan to fix this situation?
okay. Now, I'll show you the first 2 images. Can you show the first image? The first image. Yeah, this is the transeptal puncture which Dr. Srija told. The reason why we took a transeptal puncture was that in case if we need, one is to document the left atrial pressure, and number two is if you are fortunate to cross it antegradely, then that'll achieve the purpose. And number three is if suppose the valve needs to be dilated to a larger size. This has been expanded to between 18 to 19 millimeter by the surgeon during the implantation, and it can potentially go up to 22 millimeter. And if I have to go to a 22 millimeter, then I need a transeptal puncture. So I first started off with a transeptal puncture before giving the heparin, and this particular sequence, I tried as posterior and as inferior as possible so that I'm more in line with the melody valve. And this is after the entry. And then next picture, I took another next picture. This is the profile of the valve. This is to understand where is the likely to be the leak. As you saw, the ventricular end is almost flush with the mitral annulus. The atrial end is protruding into the middle of the atrial cavity. So we have to target our leak somewhere in the region of the left end of the screen. Next picture, I made through the transeptal puncture, an internal mammary artery catheter. We were able to get the wire just inside the left ventricle. However, when I pushed the wire goes into the roomy 8 centimeter aneurysmal left atrium. So I decided that it is going to be quite challenging to get it antegrade. The problem about this child is the child is only 12 kilogram and I cannot get a deflectable sheath into the left atrium. What I have is a standard Mullins sheath which is 6 French, and the curve of the Mullins sheath is far down in the inferior vena cava that I won't have any sort of anchor. If it had been a little older patient, I could have tried a Foostar sheath from the Lifetech or an Agilis sheath from the St. Jude, but right now that options are not available. So what I do right now is I'm trying a retrograde entry. So having, like you saw the previous image that I made an attempt for an antegrade entry, but my guide wire position was not stable. So now I'm trying to make a retrograde entry. So in the retrograde entry, I'm just trying to get a Judkins right coronary catheter, and I'm planning to face it a little posteriorly. So hold the. So I am trying to advance the wire. It's going into the valve.
Siva,
yes.
Hi, it's Eric here. Just
yeah, Eric.
Are you aiming to dilate the valve or put in a paraprosthetic plug?
I'm planning to put
whichever you can do.
The last will be the most appropriate answer. But right now I am trying to cross the leak and put in a device into the paravalvar leak, and after that see the left atrium, left atrial, left ventricular pressure gradient on echocardiography. And if that appears to be high, then I will try to post dilate. It's going to be a little bit more challenging to dilate it because I have to get a stable wire position through this mitral valve into the apex of the left ventricle, and you see how the wire is bouncing out at this. It's not getting into a very stable position. So right now I am trying to go across the paravalvar leak.
Well, if I saw correctly,
could get a rail?
If I saw correctly, you put the wire across the leak already from the left atrium.
From the left atrium, but
I understand it's impossible to advance because of lacking of steerable sheet, etc. However,
exactly.
If you have the wire from the venous side into the left ventricle, would you consider to snare it from the arterial side, making a circuit and facilitate progression of the catheter, either from the venous side or from the arterial side?
Okay.
That's my question.
I agree with you. Mario, the problem was the wire was not entering deep into the left ventricle. It was just borderline going into the left ventricular inflow, and it was not making any further significant progress. So
right.
I am waiting, I'm now trying it on on this projection.
Mm-hmm.
Yeah, now I'm entering. Yes, this is gone into the left atrium. Fluorostore this and come to REO view. Come to REO.
Hi, Siva. It's Salim Jivanji here. Can I ask a question while just trying to cross the leak? Have you measured the annular size of the valve currently? We do these cases in older hair quite a lot, and we find that the mitral position of the melody valve often becomes smaller as the child gets bigger. So it'd be probably useful.
It was the surgeon implanted at around 18 to 19 millimeter, and today also it measures 18 to 19 millimeter.
Okay,
There was
fine.
not much of a change. So now what I'm doing is I have got my catheter across the. So now a thermo wire has gone inside, followed by that a 4 French right coronary catheter has gone inside, and now followed by that a guide catheter, a 6 French guide catheter is now trying to get inside. I am trying. There is some
Another question. You have a probe with the 3D reconstruction possible? Because in this case, I think it's going to be very useful to have a 3D reconstruction of the annular size.
Mario, this
And
is
this
a
is what
very
you think.
small baby. The child is just 12 kilo, Mario.
Yeah, so you don't have the 3D probe,
We
transesophageal
cannot
probe,
put in
right?
such a small baby. So my only access now, see what I have now gone through is a retrograde entry. What you saw was the retrograde entry. Now I'm going to take my next wire, no, I just put your finger. I want to close this with an ADO2 device. Give me ADO2 64. Now once again, go back to Srija. Okay. Okay. Now Srija, can you show the paravalvar position of the? Go echo big, echo big. Yeah. Just confirm that I am through the paravalvar leak. I have now a guide catheter going across. Yeah, yeah,
So we can see that
Yeah, it's
nicely.
across the
yeah.
paravalve.
So now I want the ADO264 device. The reason why I'm choosing an ADO264 device is that I will have a reasonably big disc to cover up, even if I am not completely sort of snug fit into this large leak. The leak was measuring 6 to 7 millimeter, but if I get the left atrial, a left ventricular disc of around 12 millimeter across the orifice, ventricular orifice, I thought it may do something good. So this is contrast. Okay, this is a 6-4 ADO2 device. What would you take, Alison? I know that you are Mayo Clinic is the master of paravalvar leaks. So what will be your choice of the device? The leak is measuring around 6 to 7 millimeters, and
Yeah, I think that's a very good question. I was going to ask you if you had pre-procedural CT mapping, because 3D echo is pretty critical for this, because I get the idea in your coplanar TEE that there is a larger dimension, and if that largest is 7, you have plenty of room here because your valve coaptation is deep in the LA, and you can hang it into the valve itself almost to have it close.
Okay,
We have
about the-
typically still been with the AVP2 platform because we don't have the other oblong type devices, but this is an elliptical defect. So I think a little oversizing is good. I'm not sure of the tissue also.
okay.
Any other question from the panelists?
I had a discussion with the
devices?
radiologist, Alison,
question
about
from the audience?
ability to get a good quality CT image. The child's heart rate was pretty fast. The surgeon, the radiologist told that unless the heart rate is very low, this child is unlikely to have a great quality CT image for us to make some good quality measurements. Of course, we do it time and again in older patients with paravalvar leaks. But the question is, this is a 2-year-old child whose heart rate is somewhere between
Yes.
140 to 150 most of the time. And hence, the radiologist was of the opinion that a great quality CT is not going to be possible. So now what I am doing is
Sure.
I am opening out the L, okay. Now,
Yeah.
Okay, we can see your LA disc.
that's a
Yeah, it's
LV
deployed.
disc.
Yeah, it's deployed. Yeah.
And now you have your LV. Your
Yep.
fluoro is a little hard to see by shadowing of the valve. I can see
Correct,
the echo
correct.
better.
I agree with you. I agree with you. Now, I think echo
just
big,
put color, yeah.
echo big.
Now we can see maybe, yes.
Yeah. Now, color now. Yeah, there is some stuff across that area what we wanted. There is a lot of echo shadowing also. You can see that even through the membranous septum, there is through the right ventricle. What I will do is, I will try to release it so that there is no tension on the cables. Magnify this.
So I think there's still a lot of shunt there. Can echo just kind of scroll through the number of degrees to show us,
Yeah, yeah,
especially in maybe the
Yeah.
Okay.
90?
Alison, if you see, like show the fluoro also parallel, you see the LV disc is not compacting itself because of the tension. So let me first release it, Alison. You agree with me?
Sure.
Yeah. So now,
Yeah,
okay.
it compacts
Now,
better now.
now it should compact
Yeah,
better,
it
and now we should be able to assess things better, because my cable was lifting it up. Um, I am happy with the quantum of leak. It's much less. Big. Make the echo big.
Okay.
Echo big.
Yeah, it is reduced, though maybe.
Yeah.
I'm just
Well,
scanning.
may I make a comment, Siva? At this point, at least in my opinion, it's rather difficult to assess whether there is a significant residual leak or not, or if the residual leak is likely to decrease with time or not. So, my personal behavior in this situation is that because I'm not sure about that, I will try to maintain the access to left atrium, maybe by leaving an additional wire across the leak in order to be able to possibly, if needed, re-advance a sheet and put another plug. Ellison, I know that technique is very well described at Mayo for mitral leaks, making a pack of plugs there.
I think you can do sequential. It does rely on a little bit more vascular space. So
I will,
you are,
Alison,
and a rail is nice for that. This would be technically difficult in a 4-year-old.
Okay.
I would like to see the leak in this view. The other
Take away
thing
the,
I am
take away the
wondering,
take away our photograph and show the fluoro hemodynamics live. The left atrial pressure.
I'm curious now that you have one plug in place and your valve is maybe 18 and your child is older, would you consider just doing a balloon dilation also?
We will.
And then your leak may be diminished, and then you've had your valve dilation interval procedures so that you have more time between
Are
this
you able
and
to
the
see the
next
left
one.
atrial pressure? Now, previously there was a very tall V waves. Now the tallness of the V waves has significantly come down. This is the left atrial pressure. The V waves were spiking previously, but now it's far better. The systemic pressure has slightly improved from around 88 to around 97, and you now see the quantum of leak. It's actually through and through the fabric. It's not looking extremely bad at all. Let me see whether I am able to get a stable position of my antegrade catheter through the mitral valve, and if I am able to get it, then I will think about an option of dilating this melody valve. The melody valve was measuring about 18 to 19 millimeter. It was looking quite big. I'm trying to.
So I think you have a very nice position of your plug. You have at least modified the leak significantly, which is amazing in a 4-year-old child. So I think already. We don't always see the V wave go down very significantly right away, and this left atrium is very big too, so I'm sure this will be very helpful clinically to the child to be able to wean some of the medication.
Actually, the left atrial pressure has come down significantly.
Was there pulmonary hypertension to begin with, or not so much?
There was it was around 2/3 to 3/4. When the aortic pressure was about 85, the pulmonary artery pressure was close to 60 millimeters systolic, and the mean pressure of aorta was 60 when the pulmonary artery mean pressure was 42 to 43. There was about 2/3, a little more than 2/3 systemic. I am now tempted to come out and go for recording the pulmonary artery pressure. I am basically, okay, let me try to see the transmitral gradient. Now show the echo. Show the echo. The transmitral gradient is coming down because of reduction of the mitral paravalvar leak. Can you see that, Alison?
That looks very good.
Yeah.
That's encouraging. You should have a very nice result.
Yeah, so I'm tempted towards coming out now rather than doing anything more. And basically this is an ADO2 device which does not have a fabric, and we have to at least wait for another 6 hours for some amount of fibrin to get deposited. Now show the color, Srija. Make the echo big. Alison, you see that image, it's wonderful, Alison. See that? Echo
That
big?
looks great.
Echo big?
I think
I
it
think
looks
that's
much better than
very good.
before,
Yeah,
so that's very encouraging.
Excellent.
I am sure by the time I complete like another 4 hours, this is going to be like significantly be better. So Alison, I think I don't want to do anything more on this patient.
No, I think you should come to Mayo Clinic for all the mitral PVL.
Okay, Alison, now I'm moving to the next lab. There is a far more interesting case. It is a patient who has got a severe pulmonary regurgitation. One of my colleagues will now present the clinical details of the patient. PowerPoint of the second case ready?
Okay, Siva, excellent result. Congratulations. Nice, very nice demonstration.